Okay, would you introduce your case?
Okay, Dr. Lee, could you introduce?
Yeah. Let's see the case. The 68-year-old male who already received the cabbage in 2010 was admitted for abnormal finding of thallium speck without symptom. Thallium speck showed large-sized decreased perfusion in LAD territory, and his coronary risk factors were hypertension, hyperlipidemia, and ex-smoker. Next. Yeah. Next. Echocardiography showed normal LV systolic function, and the we checked the coronary angiogram, showed patent Lima to diagonal, but total occlusion at the diagonal to LAD graft portion, and the patent graft at free RA to OM and SVG to PDA graft, and revealed severe native cerebral disease.
Yes, actually he had a history of bypass surgery, but sometimes bypass graft failed. So in this case, surgeon anastomosized the Lima to diagonal branch and LAD, but the diagonal to LAD was not good. So thallium speck showed a large perfusion defect at the LAD territory. So I have a very interesting coronary angiogram. This is a patient LAD angiogram. Do you have any comment?
Or is that aneurysmal?
Yes, aneurysmal change.
Aneurysmal dilations?
Yes, aneurysmal dilation.
Just on the stenotic side, right?
Yes, right. So
can we see another view also?
Next,
another view,
please.
Epicranial.
This is epicranial. Previous things.
So the plan is to revascularize the LAD?
Yes, right. Because there is no graft, patent graft. And thallium showed a large perfusion defect and LAD territory.
It's not going to be easy to wire. Huh?
Yes, that's right.
Did you wire already or not?
So my plan is the microcatheter with a very soft wire, the field XTR. Next, this is the microcatheter, Corsair. Let's see next. Yeah, it happened.
It's very difficult to come out from an aneurysm.
Yeah, next.
Very easy to go in, but very difficult to come out.
But fortunately, I made the large curve, and I can insert wire.
easy to pass.
Congratulations. And sometimes can really be very time consuming.
Yeah.
Because when you are inside, you lose steerability and keeps on going on the walls. Sometimes makes a 360 curve goes down, but then to uncoil the curve, I mean, it's okay. At the end, you succeed, but can be time consuming. Which wire is this, the XT?
XTR.
Yeah.
XTR wire. So next, I applied the 2O high pressure balloon. After exchange to the strong backup support wire, and then I insert the IVUS catheter and evaluate the IVUS. Look at please shows the IVUS. Middle LAD is 3O, no disease at all, and some negative remodeling, mild plaque.
Distal to the aneurysm side?
Yes, right. The tight stenosis start here.
Very tight.
Very tight stenosis. And then you can see the huge aneurysm.
All right, 6 o'clock?
No.
Not
Just
yet?
a moment. Yeah, not yet. 12 o'clock maybe.
Big vessel, right?
Yeah.
Almost 4 or something.
Okay, here.
All right.
Stop, please. this is aneurysm. You can see the media around the aneurysm, so this is true aneurysm change. Run, please.
Opening, base is very large, right?
Yeah, right.
So
right.
we didn't expect that one.
So proximal, very tight. And diffuse disease.
And suckling, however, not.
Vessel is 4O, more than 4O. So fortunately, this patient have bypass surgery to the circumflex. So my initial plan is long stenting, 2 long consecutive stenting using 3O, 30, and 4O, 33 Osiris stent. Okay, I'd like to start with the procedure. Please give me the 3O 30.
Okay.
This patient LAD, usually bypass surgery patient LAD is diffuse disease, but this patient with the LAD portion is by IVUS very normal. There is a normal area. I think this patient stent result would be good in the long term. Test, please. Okay, here is initial point. Test.
You didn't do the pre-dilation?
2O, just 2O, but
2O? 2.5?
no severe calcification, so I
Right.
can 10,
10,
12,
12.
deflation,
Session.
Hold the
10.
delivery system out. Just another.
12, 14,
12, 14,
16,
16.
deflation.
Session.
I can measure the length. Test, please. Okay, more than
More than 30.
test. Okay,
Why don't you pre-dilation? So you have
Yes.
to check the really
yes. 10,
dilatable or not.
okay.
10,
10, 12, 13, 14.
14,
Good.
Okay, deflation.
depression,
Is there 33? 4?
35.
35? Okay, 4, 35.
What's then?
Osiris stent.
Size, right?
Please. 4O.
435?
Yeah, yeah. So from the to the left main ostium, because based on the IVUS, there is diffuse plaque to the left main ostium. Overlapping, it doesn't matter. So my focus is ostial coverage. Okay, test. Yes.
I think
Test.
another option is graft stent for this kind of
Test.
big aneurysm. So what do you think about the graft stent compared to this kind of native stent?
Yes.
Do you
I
have
think test. I think a graft stent would be a good option, but first the 10 inflation. But the first graft stent, the long-term patency rate is not good, and expansion is not good. So I have treated the LAD territory, the whole LAD territory. So depilation, graft stent, I think is not good option. So after stenting, it's my idea. After stenting, flow is recovered. So inside of a stent, fast flow, and outside of a stent, aneurysm area, there should be some blood status. It can make sometimes, I hope, in the future, aneurysm was packed with thrombus. Then the thrombus can be disappeared in some future.
Hope so.
Yes, it is my idea. Just
Anyway,
idea.
Chairman.
Nobody knows.
Chairman.
Yeah.
Chairman, I have a question. Okay. Yeah. So the before CABG, is there the aneurysm in LAD or not? Before CABG.
No.
No. So
Yeah.
it means so. And another comment. And
it's not.
if I am operator, I use DCB, not stent, because lesion has not hard plaque, almost organic thrombosis inside some including some calcification. It means so maybe Baron response is good, I think. Baron and DCB is better, my comment.
But tighter portion is not only to the eligible area, but also proximity and left main derived diffuse disease. So large vessel DB only is not the good option because the large vessel left main proximity high risk of recoiling. So I believe the stem procedure we have to implant it some kind of stent.
So after stenting, so how long do you use dual antibody therapy in this case?
Dual antibody therapy doesn't matter. Yes, because yes, we have to differentiate two types: acute stem malposition and late stem malposition. As late stem malposition, there is some evidence that the late stem malposition can increase the risk of stent thrombosis. But the acute stem malposition, this is definition-wise acute stem malposition. There is no any kind of evidence that the acute stem malposition increases stent thrombosis. So the
would you show us IBUS speaker? IBUS findings, great. All right. Why not?
So here is
Adiraju side?
area. Yes.
All right. 12 o'clock.
Yes.
Still on the expansion
4O.
of just the proximal part.
Yes, I can apply the 4O high pressure balloon.
Right.
It can be improved.
Yeah. 4O high pressure balloon, please.
4O high pressure, right?
Yes, right.
Great. You, Dr. An, you did really make it simple, right? Big aneurysm, so just wiring, balloon. Okay. We just drop by another cat lab, and we will be back. Okay, Dr. Bak, Dogu Bak here.
Okay.
Okay.
다 이거 TV지?
Dogu Bak.
Okay.
Can you hear me?
Okay. We're gonna introduce the one of additional interesting case, and Dr. Yoon, can you present?
This patient is 48-year-old male, was admitted for the evaluation of chest pain started 1 month ago. He underwent PCI at left main bifurcation with cross technique 1 year ago. He was not compliant to medical treatment following PCI. Next. And he had hypertension and dyslipidemia. So his clinical presentation was stable angina. Next. And his echo shows a normal ejection fraction, and STEC score was 27.
So looking at the first phase, and 1 year ago, and I performed the crush technique is put the ultimaster circle ostium is 3.015, and left main to LAD is 4.024. So after 6 months follow, patient was reluctant to receive medication is unfortunately dropped the depth therapy and any statin therapies, everything is go to just the vegetation, something like that, the herb medication. So the recurrent chest pain. So this is the initial baseline view, and looking at the RAO coral view is the very tight stenosis, the sarcosteum, and also very tight stenosis, the LAD ostium, and the distal main also looks some neointimal hyperplasia. Next. This is the spiral view, and this is jogging guidance caster. We can see the sarcosteum looks very tight, and the LAD ostium also looks very tight. And then next. This is the epicranial view. We can see is definitely instant restenosis region. The prox LAD looks very tight. also the distal part of the LED stand is there is some haziness. So we check the intravascular ultrasound. Okay, can you see the IBUS finding? This is the LED, and then looking at the distal part of LED, there is a huge plaque. Is a lumen area is less than, looks like 3.0, and the plaque was progression. The heat didn't receive any statin therapies and DAP therapy, and stopped all medication. Looking at the distal part of the LED stand, prior 4.0 stand is very expanded, but the neurointimal hyperplasia is huge. It's an encircling plaque in neurointimal hyperplasia. Lumen is very tight, and then the thoroughly encircling, and the sock is coming the 6 o'clock, and we can see the lumen size is expansion is good, but the neurointimal hyperplasia is the main mechanism of the LED.
Main cause is intimal hyperplasia. No?
Yeah, right. And then next, we also check the
circumference.
Okay.
It's a very soft plaque, right?
Yeah,
Just 6 months ago you did.
Yeah, right. And the distal part of the sock, and could you show us the previous one? Sock, okay.
Great.
This is a 3.0 on the basis of IBUS. We put this side 3.0 stand, and then lumen size 3.0 is okay, but this is the austere part of sock. There is a hyperplasia of the sock ostium. Is homogeneous, and at the time we performed the crush technique, and then this is 3.0. At the time we performed slightly on the expansion the area, right. Yeah, and also the some neurointimal hyperplasia is the main mechanism of LED ostium, and distal part of sock, and the sock ostium there is some on the expansion. So how do you treat this patient? This is the first ISR case after the complex two-stand technique for distal left main bifurcation, treated with Ultimaster. Any comment from audience or panel or moderator?
But when I face instant restenosis, the decision comes after predilatation. I do the best possible predilatation, and then if the result of the predilatation is really very good, I do drug-eluting balloon. If it's not good, I do double stenting or single stenting. Here, maybe it could be a good on one vessel, so maybe you can just get away with one single stent. So, as always, if you can avoid to stent the circumflex, is better. So I would do all my effort to optimize predilatation.
Okay.
After predilatation, I do IVUS, and I check with IVUS. If the result is good, I take one way or the other.
So today is very happy that Colombo suggestion is always the same to my initial intention.
Circumflexural ostium had some part of under expansion.
Yeah,
right.
right.
Could you, why?
Okay.
Is it mini crush?
Yeah, this is the mini crush at the time.
So you did hyperpressure inflation.
Yeah, right. It's and next and the distal end of stand there is we recheck the IBUS again. Is that there is some significant plaque. Is the distal part of the prior LED stand. Is the lumen is 3.0. Is encircling the de novo region, and put the additional stand is just a small overlap with the 3.0 18 giant stand, and then next, and then put the short segment of additional stand, minimal overlap, and then next, I did pre-dilation using 3.5 non-compliant balloon. Is aggressively to the mid prox LED up to the distal left main. Is I performed the 4 and 5 times 3.5 non-compliant balloon up to 25 or 30 ATM next. And then this is I try to match the proximal part of the left main and the next. This is 3.5 NC balloon inflate up to 30 ATM. This is 3.0 additional non-compliant balloon. Is I try to match the distal end of a segment and the next. And then the 3.0 the high pressure non-compliant balloon next. And the next is performed several times 3.0 up to 30 ATM, 35 ATM, and next. And then I do kissing balloon dilation using two non-compliant balloon, 3.5, 3.0, and the kissing balloon dilation next. Sequential high pressure dilation, and the slightly pullback next. Slightly pullback next. Some the slippage of the LAD, and then I do on 4 and 5 the kissing balloon dilation, and then I'm gonna check again. Okay, test.
Okay. Dr. Bach, so,
Okay.
Dr. Bach, so as
Yes.
you emphasized previously,
Yes.
before circus ballooning, why don't you check the FFR value
It's a
for circus
yeah. This
functional
you know,
guided procedure?
yeah. You know, this patient is we didn't check the FFR. Is initially the flow was compromised. It's very tight. In the prior case, we checked the FFR. There is some intermediate region, but for this case, I didn't check the FFR. Okay, Angel, ready?
Another issue
Sure.
is, Dr. Seung, actually for particular these cases, we have treated to be, in fact, is if there are FFR negative for the circumference, however,
Angel.
this kind of region we have to treat both sides in terms of just more compromise
good.
and
자,
so.
NC볼
And also, I think is this, we have some evidence,
Okay, got it.
very unstable.
So just we remain the final step that we perform the optimization using 3.5, 3.0, and we did already kissing balloon dilation 4 and 5 times. And then this is I'm gonna apply the 3.0 the Pantera for sock region, and then I'm gonna do additional 3.5 dB, and then the short moment of kissing balloon, and then finish the procedure. This is 3.0. Prior stand is 3.015. Okay, passed well. Okay, 이쯤 맞았지? 자, go. 7,
7,
8,
8,
9, 10. 시간 재세요. 12.
12.
Okay, 시간 재. Okay. We check the patient symptom and hemodynamics and the time. Okay.
You didn't do the obvious after the kissing balloon inflation, right?
Yeah.
Not yet.
It's not yet. And
Right.
after DB and final kissing, we recheck the final IBUS again, and the 25, 26 second. Okay, it's slightly ST change. Okay, deeply. Okay, got it. So we apply the nearly 40 second, and then 여기 놓고 additional dB for 3.5 length is 25. Prior is
In some patients with aggressive in-stent restenosis, we have been using for the past 2 years a combination of first drug-eluting balloon and then in the same session drug-eluting stent.
자, go. 6, 8, 10, 12, 14, 3.5, 16.
dB.
Yeah, dB.
All
Okay. Time goes on. Okay, 시간 재고 있고. Check the symptom and blood pressure. Currently, we just available 2 paclitaxel drug-eluting balloon with Pantera and the chicken freeze, and another companies tried to make some another Remus eluting drug TCB. Okay, 35, 34. Okay, deeply. Okay, got it.
There is, wake up. There is not Limus.
오케이, 됐어. 샤롯 괜찮고 조금만 기다려. 오케이, blood pressure is good. 잠깐만.
제가 써.
조금 보자. 오케이, 됐어. 누구지?
에리딘.
슛. 한 번만 탁 하고 나올 거야. 자, this is DB 좀 빼고.
DB.
Yes. 오케이, go. 6, 8, 10. 보면서. 12, 14. 오케이, 1, 2, 3. 오케이, 됐어. Okay, I did everything. We're gonna check the IBUS again. Okay, Angel, ready?
Ready?
Okay, shoot.
Great. Would you show us a spider?
Yes, I'm
No
gonna
question
do.
that you really did a very meticulous pre-dilatation.
Yeah, right. Nitro and then spider view.
Very well.
I think as emphasized by Antonio Colombo several times at this session, pre-interventional pre-preparation is, I think, the most important thing to make guarantee the optimal result of the complex PCI. Is, for calcified region, bifurcation region, ISL region, distal main region preparation is, I think, first. Okay, Angel, ready?
Ready?
Shoot. Okay, we're gonna check the IBUS.
We rediscovered the value of lesion preparation when we started to use BVS. BVS made us more aware of lesion preparation. We did it for another reason, but we discovered, as a matter of fact, we have used BVS for 4 years.
Okay, this end.
We have
Okay,
more
got
than
it.
350 patients treated with BVS. And our follow-up of those patients is excellent.
This is
We
suck.
never had such good result with metastent. But I don't think it has anything to do with BVS. It's to do with the lesion preparation we made
Yeah,
for those
definitely.
devices.
Yeah. This is the sock ostium, and the stand is a much expanded well. This is the ostium of sock. I think it's much improved. And then we're gonna check again from the LAD to the left main. Okay, some current available data and shows the TCB is comparable compared to the contemporary drug delivering stand. Like if there is concern about too much overlap of the stand strut, I think TCB and DEB is a very nice option to treat the ISL region. And this complex PCI meeting shows many, some available case treat well with TCB alone. Okay, this is distal part of the LAD. Okay, go.
Ready?
Yes.
Great.
On the basis of IBUS and the short, we put the additional short segment of 3.0 is to cover the plot area. Okay.
At least 275.
Yes.
Send diameter 30. 6 to 7 millimeter squares.
Then the region is fully dilated. This diagonal branch is coming, and there is some prior neointimal hypoplasia nearly disappear, and we did meticulous region preparation using non-compliant balloon, and this is just the end of the final kissing, and the lumen is okay. And the sock ostium is coming the 7 o'clock, and the opening is good. And we did kissing balloon dilation using non-compliant balloon several times, and finally also we performed the kissing balloon dilation. Okay, lesion is covered the main ostium. So I removed all system and check the final angel. Okay, Angel, ready? Full shot. Okay.
Great.
Yeah, I think the lesion is good. We're gonna check the spider view. Okay, Angel. Full shot. Okay, good. And then the areocranial view.
Do you think that the index procedure was like this or was inferior? Have you had a chance to examine the baseline?
Yeah, at the time I performed this patient is my patient. At the time, I think we checked the end of the final procedure angiogram. Looks like perfect, but at every time I do my best, but
Did you do IBUS as the index procedure?
Yeah, right. Exactly. Almost all cases we did IBUS-based PCI, especially for main and complex case.
Dr. Pa,
yes.
Theoretical.
There was a stent under expansion at the ostium of the circumference. Do you think that this was a kind of recoil of compression?
Yes. So at this time I didn't recheck the end of the IBUS. But usually we try to meet our value 5, 6, 7, 8. But might be there is some possibility about the recoil or the ostial region is sometimes vulnerable to recoil. So it's the one of mechanism for the sarcoostial ISR region. I checked again at the time final IBUS and I'll let you know.
Any other? I have theoretical questions about the DEB in this left-wing ISR treatment. Do you worry about the dose of paclitaxel in the left wing because we double treat the left wing with 2 times DEB?
So that is your question?
The dose, the paclitaxel DEB, you do it
it's your overlapped area.
The left wing, so the left wing receive two doses of paclitaxel.
Yeah,
it's theoretical.
Yes, we frequently do. Sometimes long ISR region is distal part and proximal part. There is the intervening zone is the center zone. There is some 2 overlapped paclitaxel coated dose, but we performed our restore trial looking at the 2 dosing areas. So we didn't see some particular finding.
Okay, so you mean you worry about the two balloon in the main,
too much toxin,
overdose? I think it's not too much concern about that. The meaning is in the balloon, paclitaxel also usually very high concentration paclitaxel. The reason why in order to diffuse to the vessel wall, and so to be honest, I think the high concentrations may be better than the reason why. Okay, Duk-Woo.
Okay.
Yes. In this case, must be last one for you.
I remaining just one.
Remaining one. Okay. All right. In the later, say hello in the later.
Okay. Thank you.
We're gonna move to the Dr. An. Dr. An.
Yes.
Okay.
Can you see the final angiogram, the epicranial view, the 3O?
Nothing changes. Aneurysm up there.
Yes, but the time goes by. I hope time goes by and aneurysm will disappear. So this with the LAD is 3O, the proxy to left main is 4O stent implantation. Let's just see the IVUS. This is the distal part of a stent. Lumen is at least more than 3. I applied the low pressure with the 4O stent to save the money. And the stent expansion is good. So stent minimal lumen area more than 10. So some eccentric expansion, but this is due to the eccentric distribution of native plaque. Here is the aneurysmal area.
12 o'clock?
Yes, 12 o'clock. And proximal to the aneurysm. Some eccentric expansion. But the lumen area is more than 8 something. We will measure the lumen area. So here is
lumen area?
Yes,
11,
more than
12.
yeah.
Big enough.
Yes. So here is a 4O stent implanted
Almost
to the left
12.
main ostium.
Okay.
almost there. Here is a circumflex is coming from the 11 o'clock. Here is the left main. I applied for all high pressure balloon up to 24, 26. Here is ostium.
Excellent, excellent.
Yes, well matched and the proximal part. So great cases. Make it really make it simple for complex region subset. And this is your last one. Another one?
Yes, another cases maybe. The officially officially this is my final case.
Officially, all right.
Yeah.
So, you look good so far. So maybe next year we wanna prepare some more cases in the later after. Okay.
Okay. Thank you, Dr. Park.
필형. Okay. Alright, we're gonna see later. So 필형.
조금 더 들어갈까요?
조금만 더.
들어가겠습니다.
필형 Lee, Dr. Lee. Can you hear me?
Yeah.
Great.
Okay, hello.
Good.
괜찮아.
This is room number 4.
오케이, 앉아.
Yes.
Alright. Would you explain your cases first?
Okay, this is a
괜찮습니다.
critical point, so I will just do my stenting and then explain our case. 가자.
네, 가겠습니다.
야.
노미랑 하겠습니다.
11, 12.
12.
Okay. Depletion.
Case first.
Okay.
Alright.
Could you explain our case,
Those
please?
cases, right? Great.
Yeah.
81.
This patient is the 81-year-old female is admitted for evaluation of the exertional chest pain. Started 3 months ago. So we checked the angiography and then cerebral vessel disease. And then you can see the demographics is diabetes and hypertension, hyperlipidemia. And clinical presentation is stable angina. Next. And as you can see, the functional test showed the RCA perfusion defect and small AAA in the abdominal worker. So we already fixed the LAD and circumflex. Today we focus on the RCA intervention because of the very tortuous and some calcification.
Yes.
So maybe we need some focusing the tortuosity and the calcification.
Right. So actually, this patient has a critical stenosis at the proximal circumflex and proximal LAD. So the SPECT finding is, I think the ischemia burden has been underestimated by the SPECT. We already fixed the left coronary artery system, and today we're dealing with the right coronary system. And this is the baseline angio. You may think that this this lesion may be a little bit relatively simple, but if you look at another view, there's some tortuosity at the mid portion at the distal RCA. So I think a bad portion, bad portion of this anatomy is that this patient has some calcium at the lesion and some tortuosity going around the 360 degree 2 times. The good thing that I think is that the calcium location is in the lesser curvature area, which considering that the stent, if you deliver the stent, the friction always usually occurs at the greater curvature thing. And if you look at the baseline, there is a competition flow at the PL branch there. This patient has a collateral from the circumflex to the PL, so that's another good portion for this patient. So we already, as you saw, we already put the stent, so we will explain our procedure. Actually, we used the JR catheter because the coronary ostium was a little bit lower positioned, and we had discussed to use the JR and use a straightforward strategy for this patient, because if we usually, in our experience, if we introduce the wire, there the accordion phenomenon occurs and the flow is compromised usually. So that was anticipated. So in this kind of case, the work is to go straight forward, put the stent rapidly, and do the stent optimization later. So as you can see, we put the wire at the distal portion.
Sion wire.
This is a Sion wire going in through.
Not too much difficulties?
Yeah, it was relatively easy.
Great.
But suddenly the patient feels some chest pain, and you can see the flow is compromised to distal. So at that time, we introduced the Guidezilla and did the rapid ballooning using 2.5 millimeter balloon, and introduced the Guidezilla more deeply, and dilated the critical stenosis located at the distal RCA, and then rapidly changed to put the stent there. That this distal, we already had some landing zone at the distal. This is a 3.038 millimeter stent. Deployed it. And then we tried to use another stent at the proximal. You can see the flow is getting better to the distal. At this time, the patient was relatively stable. Because the stent did not go in, we used another balloon 2.5 and anchored at the distal stent and introduced the Guidezilla like this, and put the Guidezilla tip at the mid portion of the stent, considering the friction occurring when you introduce the second stent at the proximal. And finally, we tried to locate this stent at the proximal toward the ostium like this. This is 3.5, 32 millimeter stent, and deployed it. This is our current status.
Great.
So we would like to.
Second lesion is so tight to the region.
Yes.
After the wire pass, some hemodynamic changes. So
we would like to do the IVUS and do the stent optimization.
Why don't you check up, angel first?
Okay. Right. Okay. And you ready?
Digital part.
I'm sorry.
Okay.
I'm ready again.
Ready? Okay.
Great.
Not so bad, I think. So IVUS, please.
IVUS.
Okay.
According to this angiogram, proximal part of the RCA may be a little bit underexpanded. So we need to dilate the proximal RCA a little bit more. Let's check the IVUS first.
Sure.
Okay, this is our IVUS finding. I think the distal landing zone is okay. The vessel size is about 3.2, 3.3 vessel. Somewhat underexpanded here.
Distal part stent, what size? 3.0?
3.0.
3.0.
Okay.
Still a part, this part, a little bit under expansion.
Underexpanded. The vessel size is growing here.
4. Big
up
vessel.
to 4. Yes, big vessel.
Proximal stent size is 3.5, 3.0?
3.5.
3.5, 3.0,
Yes.
3.5, right?
Yes.
Vessel size is bigger than that, almost 4, something, right?
Can be improved.
This was a branch. You can see some eccentric plug with calcification here. So definitely we need non-compliant balloon to do the high pressure.
What size?
Well, I would like to use 3.5 first.
3.5?
3.5.
Okay.
Yes. 3.5 non-compliant balloon 주십시오.
Proximal.
This is the proximal. A little bit underexpanded. Oh.
Absolutely.
Okay.
Anyway.
I will. 잠깐만. 그대로 봅시다.
Wow, exactly. Wow.
Well, location is not bad. I think I missed one or two strut at the ostium, but I think it's okay. 3.75요?
Could you see the vessel size?
How about the vessel size?
Vista. How about proximal?
This
One part is maybe really the 7.5 something.
Okay.
7.5.
We will use 3.75 non-compliant balloon.
Okay. 볼론 하고 더 하자.
네네, 잠깐만요. Okay, I feel some resistance. I'll do the anchoring technique. 여기 좀 잡아주세요, 지금.
볼론 하면서 더 하자.
네네. Okay, go. 10, 12.
와요.
Still guided lines inside? No?
No.
No.
Okay, deflation.
Okay.
And push in.
Okay.
Great.
자, okay. 10, 12. Okay.
20.
Okay. 20, deflation.
Push
천천히. Slowly.
Gradual.
갑시다. 14.
Come on.
잠깐만요.
Two layer.
Guiding.
Actually, it's over there.
가이드 인게이지.
네. Okay, deflation.
천천히. 리플이 다 된 다음에.
네.
Okay. One more time. Go
Okay,
20.
go.
20.
20.
Okay.
Okay.
와요.
Okay, deflation.
천천히.
Further.
Okay, 20. Okay, 잠깐만요. 가이딩.
가이드 좀 눕혀라.
네, 조금 더 할게요. Okay, deflation. Okay, go. 20. 잠깐만요. Push the guiding. This.
와요.
Position the wire. Okay, deflation.
Please.
Further.
Okay, let's
go.
go.
14. 네. Okay, 잠시만요. Reposition the guiding. Okay, deflation.
14라고 14.
Okay, 12.
Great.
Okay.
Wow.
천천히.
You have to
Okay, deflation.
remind the very proximal side that there was an underexpanded area.
Yes, right. I will do it. Oh.
천천히 와이 좀 들었고.
Wine.
자, 14. 16.
16입니다.
Okay. Okay, deflation. After the balloon, introduce the wire.
Okay.
Okay. So I position the.
A little bit
Great.
out.
I pull out a
Okay.
little bit.
Okay.
자, 12.
네, 노미널만 하겠습니다.
Nominal.
Okay.
Okay. Deflation. Again, 16. This is 3.75 balloon. Okay. Deflation.
천천히. Okay.
Okay. Slowly, 20. Because the vessel is more than 4.5 in this portion. Deflation. Okay, 20.
20.
Okay.
Okay.
Deflation.
옷 나왔어.
I'll pull the high pressure balloon a little bit out to the ostium. Oh. Okay, go. 20.
Great.
Okay, patient. I think I have to
조금만,
come out a little bit
A
more.
little bit more.
Yes.
High pressure 20, 25.
Okay, 20.
Okay. 20, 25.
Make a full.
25.
Make a full awesome.
Yeah,
Okay,
yeah.
25. Deflation.
A little bit. 조금만 더 나왔어. Okay. Okay.
자, 갑시다.
Let's go.
25.
네.
Okay.
Good. Deflation.
Good.
Okay. So we check the angel.
Angel.
Angel, ready? Wow.
Great. I like it. You know the ibis?
Yes, after I will check the, the
All right,
finding
so-
and finish the procedure.
Okay, we will be back in the, as you know, after the ibis evaluation. So Dr.
Okay.
Bach, Dr. Bach, can you
Yes,
hear me?
okay. Okay.
All right.
됐어?
Must be
Okay.
last one, right?
Yeah, this is the last case. Really
All
last
right,
case.
All right. Long journey.
Okay. Okay, the Dr. Bach, and can you explain the patient history and background? 우리 여기 영상 보여줘요. PowerPoint.
Yeah.
Okay.
A 63-years-old male was admitted for dyspnea on injection. He had received cabbage rheumatoid T-Lima to RI. In 2009, his current risk factors were diabetes, hypertension, and ex-smoker. Next. His current risk factor is diabetes, hypertension, and ex-smoker, and clinical prevalence is stable angina. Next. His echocardiography shows normal systolic function without regional or motion abnormality, and some defects, liver medium-sized defect in mid-basal infralateral. So we checked the coronary angiogram. The coronary angiogram showed rheumatoid graft patent and T-Lima to RI graft total occlusion and severe ectomic stenosis and diffuse stenosis and severe circumflex stenosis and severe ramus stenosis. Next. So he had cytoma defect in left circumflex territory, and we make plan to PCI to circumflex.
Okay, if I'm going to summarize this patient background history, and he underwent bypass surgery 2009, nearly 10 years ago, and sometimes upper chest pain patient complained, and we checked the Thallium scan. Thallium scan is remained the large size perfusion defect anterolateral, the sulcus territory area. And we checked the coronary angio LIMA 2 LAD is patent, and this is a protected PCI. And looking at the spiral view, there was a sulcus region. initial 첫 번째 뷰가 뭐지?
Baseline.
Baseline, the angio area coral view. Looking at the area coral view is a very tight stenosis of the sulcus ostium in the sulcus ostium region is the one OM branch and the one true sulcus. And the really true sulcus region is looks like some CTO region. And the next. So and this is the LAD is the limma graft is patent. Next. So in the we put the two wire the Ramus branch and then the sulcus branch, and we checked IVUS for Ramus branch. Can you show us the IVUS? This is okay. Yes. Ramus branch. And it's 2.5. Yes. 조금 더 나오면 이게 오스 저스트 오스만 한번 보여줄 수 있어? 쭉 해서 저스트 오스. Okay, go. Yes. This is Ramus ostium. There is some superficial calcium of ostium. And so wiring of the sulcus ostium is not easy. This is used crusade caster. Yes, and then the wiring is done by Dr. Kang and the past well, and the next crusade caster. And then successfully wired, but the passage of the IVUS doesn't work, and because of severe calcification. And then next, at first performed, this is 3.0, 2.0 compliant balloon doesn't work. Next, and that this is the 2.0. Next.
Would you show us? Okay, good.
Yes. This is a 2.0. Okay,
the encircling narrowing
calcium.
portion
Yeah,
is the distal limb main area, right?
Yeah, definitely.
Right.
Yeah, and then next. So and then next is we do try to the predilation is next. This is 2.5 non-compliant compliant balloon. Next, and the next is doesn't dilated well, and next. This is 2.5 non-compliant balloon, but the stenotic area doesn't expand well. And next, yeah, right. So if doesn't work, and we finally decide to the rotabulator, this is.
Why don't you use cutting balloons?
Yes, cutting balloon. I didn't try it, but it's next step.
All right, so encircling very short.
Yeah, right. And then next, and then this is 3.0, 3.0 compliant, non-compliant balloon is work well here and past that area, and then next, and then we inflated up to 30 ATM using the non-compliant balloon. This is a non-compliant balloon 3.0 is we inflated up to 30 ATM is we performed 3 times. At this point, we checked the IBUS again. Okay, could you show us the IBUS after the predilation using the? This is
still do something more. I mean,
yeah,
I
right.
will do cutting.
Yeah,
because
right.
It's better, but it's not.
Okay, this is some cracked calcium area. We can see
Breakdown.
the severe dissection and breakdown. We can see the some.
It's broken the calcium.
Yeah, right. So
Yeah,
if this stage is non-compliant balloon doesn't work, and my intention was to adapt rotabulation, and the plug is
there are fractures.
And then next step, and we directly put the 4.0 18 is on the basis of IBUS. This is a giant stand. Is among the contemporary drug loading stand. Radial pulse is a giant, and the resolute is best. And then we inflate 4.0, and then next. This is 4.0. There is some under expanded area is calcium. Distal. And then next, we apply the 4.0 additional NC balloon 1 time, and next, and 2 time, and next 3 time, and next 4 time, 5 time, 6 time. We did aggressive, non-compliant balloon dilation.
This is the way to do it. This is not aggressive. It's appropriate.
Yeah, right.
Appropriate.
On the next, there is some compromised flow, and we exchange the wire to Ramesh branch using the choice PT. And then next, 우리가 그리고 IBUS 체크했나 지금? Finally, 안 체크해가? Okay. Okay, we're gonna hear.
Beautiful to see PCI well done. It's not.
Ready?
It's not easy to see.
Antonio really likes.
Thank you. Okay, good.
It's not easy to see. It's like when you see a beautiful new movie, you read a nice book, something gives you pleasure.
Antonio, really appreciate your comment today.
No,
I think it's very simple.
You go to meetings, you don't see the things anymore.
Sure.
They just need to finish. Bing, boom, bang, finish.
Okay, so it's up the proximal area there is some inner position. We additionally do 5.0 non-compliant balloon. Try to remove the stand inner position. We will 이거 뭐야? 우리 5주년에 해야 되지. Okay, the proximal the segment of a stand there is some still in a position. This is 5.0. In the Giant Sierra, we can inflate up to 5.5. This is still Giant Alpine. It's 짧은 거지, 10mm. 프락시마 엣지만 딱 해주면 돼. 한번 봐봐. 조금 더 들어가야 돼. 한 요 정도네. 한번 다시 볼게. 그치? 여기다 잡고 10, 12, 14. This is a 5.0, 14. Okay, deplete. This is try to remove inner position. Okay, go.
I think it's enough.
한번 더 12.
Quite enough.
I think it's
Okay. Okay, deplete. And then
Alright.
check the angel and then check the final ibis again. Okay, angel ready. Okay, shoot. Okay.
Great,
I
great.
think it's.
All right.
Yes.
I think it looks
okay.
like a femoral vessel.
Thank you. Okay, at this point, I'm gonna check the. I don't want to touch the distal part of some Ramus.
Some disease, and so
yeah.
you don't touch it by
Yeah, definitely,
any
definitely,
devices,
yeah.
any
Yes.
others. It's just, I think it's good result.
Yes. Yes.
All right.
Okay, I'm gonna check the ibis again. 오케이, 자 들어가지. 디지털 랜딩 엣지에서만 볼게. 잠깐만, 칼슘이 있어서 조금만 더 앞에 밀었지.
네.
오케이, got it.
Okay, I think it's enough.
오케이, 여기서부터. 오케이, go, start. Okay, this is the most stenotic area is previously, and some elliptical, but we try to our best. And this is the.
That is mean
Yeah.
area, right? Distal
Yes.
and mean. Narrowest portions, wide
Yes.
open.
Yes.
Calcification breakdown.
This is the left main size is a 5.2, 3. Even though there is some inner position, usually it's okay. It
Yeah,
doesn't
it's
matter.
when
Yeah.
you have such a big vessel.
Okay, okay, got it. So I think this is my
Right.
some
Great.
the moment of I can do best. Okay, I removed everything and
All
check
right.
the
Good.
final angel. Okay, angel ready. Shoot. Good. And then I check
Okay.
area coral view.
Duk-Woo, you did really a great job for long days.
Yeah.
We have still many attendees here, so I really
Yes.
enjoyed your walk and our family's walk, and so
Okay.
why don't you say goodbye?
Yes, really
Maybe next
appreciate
year
the-
just 30 cases in a day.
Yes, I can do more 10 cases today. But I think this time is a very nice time to discuss a lot of cutting edge technology with some worldwide expert. Is Antonio Colombo, Alan Young, is many experts contribute. Our meeting is really appreciate is we prepare the next year much richer event. It's really appreciate all moderator and panelists, all audience. Thank you.
Great. All right, son.